us from Dubai. Again, we are live. So with another legend of bariatric surgery and expert of MGB from another part of the world, from Mexico. So it is great honor for me to interview Professor Francisco from Mexico. He is also legend of bariatric surgery and great experience in MGB, OAGB. So I feel great honor and also privilege to interview such a prestigious figure. Sir Francisco, over to you, sir, please.
Oh, thank you very much. I'm very grateful and honored for the invitation, Dr. Imran, to participate in this forum. And I will talk a little about my personal and institutional experience about the OAGB. I'm Dr. Francisco Campos, as you said. I am from Mexico City. I was the founder of the Clinic of Surgical Attention for Obesity and Metabolic Surgery in Mexico City. And I am professor of the National Autonomous Mexican University. I direct this program, this free program. This was very interesting because I direct this program for more than 10 years. And we made more than 3,000 surgeries during all this time. So when I met the Dr. Carvalho in 2013, I began to be interested in OGB. And after this, I knew Dr. Robert Rutledge, good friend, also too. And we started to do OAGB in the tournament when in those years were very difficult for the OAGB. If you remember Congress like Austria, like another cities, it was really difficult to talk about OAGB. Actually, I know both techniques, Dr. Carvalho and Dr. Rutledge. Actually, I do a technique similar to the Rutledge because to me, I don't find qualitative difference between the two techniques. And the results obtained in the development of this technique for the benefit of patients and the advantage for short-term surgery, easily reversible and revisable. That's the answer to your first questions.
Sir, thank you, sir. So this is also your introduction. And sir, just as you have mentioned, so your institution, so you crossed 3,000 cases of MGB or OAGB. So during this journey of doing MGB, OAGB, definitely you have changed some parts of your technique for better results. So which parts you have changed personally? So length of pouch, this width of gastrojejunostomy, or length of this BP limb length. So, and for better results, have you changed any steps during this period?
Well, usually, I think that the only thing that we change is the size of the pouch. We try to do a pouch from more than 20 centimeters, and we calibrate with a tube of 32. The anastomosis, we do it in the posterior face of the stomach. And more ahead, I would like to comment this. Right now, we are doing no more than 2 meters of biliopancreatic limb. This is the only thing that we change. But I want to mention something. 3,000 surgeries, not only the OAGB, is all bypass, is sleeves, and OAGB. OAGB, we cross more, I think that we did more than 550. And stop this because the clinic stopped past year because the pandemic. And now many of hospitals must be reconverted for attend the problem of COVID.
Sir, excellent. So, as you have mentioned, so this is the technique of Carbajo that we call it OAGB, because I know about this. OAGB is more restrictive and as well as more absorptive, because Carbajo, so he routinely he count or measure all the small bowel, and his pouch is very tight, as well as this gastrojejunostomy is also size is smaller than MGBOT, original technique of Rutledge. So in technique of Rutledge, our pouch is little wide, dilated pouch, and length of BP is not very aggressive. Same, this gastrojejunostomy is little wide. Maybe the main experience or patients of Robert Rutledge is Indian and vegetarian, maybe. And so the main practice of Carbajo is in Spain, and they use more protein. So their diet is high fat and high protein, maybe. So due to this, so Professor Carbajo, this technique is little aggressive, also more malabsorptive or hypoabsorptive, and as well as to MGBOT, also more restrictive. But so as you as informed, so we will watch your video. Most of us, personally also myself, so our technique is mixture of these both of them. So some points from Carbajo, some points from Robert Rutledge, and then we achieve the target. Say maybe your technique is also mixture of both of them.
Yes. Well, I think that can you see the video?
Yeah, sir. You can show, please.
Yes. This is a video of 4 minutes. We start like usually, trying to open the window near the crow's root.
Sir, you can share if your video is ready. So just you can click share screen.
Yeah, sure.
Yeah. You can click here, share screen, and then you can share your video. And
sorry.
So just you can see this green button downside.
Yes.
And you can click here, share screen, and then you will access to your desktop. And then you can share your screen as well as your video.
Is there?
Not yet. So you can try. So you can share. So just you can click this share screen. Have you seen that button, share screen?
No.
So just with mouse you can work little. When you will work with mouse at your this laptop screen, so you will see share screen. That is a green button.
Yes.
It will come. And then when you will click share screen, then you can be able to share your video.
No, I can share the desktop. I have this in the desktop.
No, you have no access to your desktop. Okay, no issue. We will go ahead, sir, no issue. So just you can explain. So I will also ask some question regarding this your technique, but already you have just informed. So your pouch is lengthy now,
yes.
And also you will not cross 200 centimeter of BP limb. So the some little mixture of Carbajo and Robert Rutledge original technique. Sir, I have a question. So as also in your earlier, so you have informed about this. So there was some resistance against MGB. So what was the concern? I also remember when I have started MGB, I have started in 2013. So I was the main person, I remember, against MGB. Always we talk against this. So this is not good surgery. It will cause marginal ulcer. It will cause malignancy and different things that personally I remember in different conferences. Always I have talked against this technique. I remember at that time, because at that time my main practice was sleeve gastrectomy and Roux-en-Y gastric bypass. So that is also good surgery. We are not against the surgery, and also a good bariatric surgeon must do all types of surgeries. We are not against any type. So what is my question now? So as also you remember now, some months ago, Di Maria also mentioned, so the main concern of MGB is marginal ulcer and bile reflux, not acid reflux, he mentioned. So in this 2021, after all of these technical changes, and so we know now how we do, is still this is a concern, these 2 points, marginal ulcer and bile reflux after MGB? What is your experience?
Well, my experience at this point in marginal ulcer, we never have to do surgery for this eating. However, we have almost 40.5% of reflux that we convert mini gastric, special mini gastric, both techniques, mini gastric and BAWA, to bypass conventional. And I think that the fear is still valid, because one of the things, that's my personal opinion, that many people doesn't report the real reflux or do not do endoscopy previously and posterior to the surgery. The only person who reports high reflux is Mario Musella, but the rest of the people doesn't do it. In our series, we present a series in Egypt 2 years ago, and we have 4.5% of reflux that need to convert to bypass. Marginal ulcer usually was treated with the PPI, sucral fat, and prokinetics, and resolved between 6 and 12 weeks. We never have a patient to convert for a marginal ulcer.
Sir, excellent, sir. But so as you have mentioned, so about 14%.
No.
4% or 14% you have convert?
No, 4.5%.
Yeah, 4.5% cases due to bile reflux. So before surgery, this second time, not previous. So have you confirmed that was bile reflux or acid reflux that you convert to Roux-en-Y gastric bypass?
Yes, in all these patients, the reflux was untractable, because the patients cannot live with this reflux. We try first in our protocol with medication. In all these patients have endoscopy, previous endoscopy, transoperatory endoscopy, and postoperatory endoscopy, or management posterior to the bypass, mini gastric bypass, is endoscopy every 3, 6, and 12 months after the endoscopy. So these patients, it was impossible to treat only with surgery.
Sir, my question, so all of these patients after Roux-en-Y gastric bypass, now they have no complaint? They are happy?
Sorry?
All of these your cases that you have so changed to Roux-en-Y gastric bypass, now they have no complaint? They are happy?
No, No. All these patients that we convert to bypass, all of they, just 2 of them continue with reflux, even with the bypass. This is paradox, but we think that the reflux is very difficult to manage when it appears like a complication of the mini gastric bypass or BAGWA, because we saw the same in both techniques, reflux in both techniques.
Sir, because as you have mentioned, so this is your routine practice. So you do endoscopy for all of your cases before going to do bariatric surgery. So what is my question? So in a case with symptomatic reflux and also documented reflux, also your endoscopist confirm there is a reflux, or you go for MGB in such a case?
No. It's one of the reasons not to do OAGP when we find reflux, clinical and endoscopy. We decide to do another technique. Usually we do bypass.
You do bypass. So my question, sir, so now more than 500 cases you did, or your team, so you have experience of MGB or OAGB during this period, or you remember you did MGB in a case with reflux and situation become worse or become good? Or you remember any case, or no? You never did any MGB in a documented or in a clinical?
No.
You never did?
No, never did. Never did, because for us, endoscopy is mandatory in all the patients, independent the technique that we are going to perform.
So definite, sir, when you are not prefer in a primary surgery, a patient with reflux, definite you will not go in a redo surgery, as some cases after a sleeve gastrectomy, patient is suffering with GERD, with reflux, definite you will not go for MGB in such a case?
No.
Okay.
No.
Yeah. Sir, this another question regarding eradication of H. pylori. So this is your protocol? Routinely you eradicate H. pylori?
Yes. Always that we do endoscopy, we take a biopsy, and it is positive for Helicobacter pylori. We give treatment with medications for 2 or 4 weeks before the surgery. And
have you any follow-up? Because you also just now you have informed, so you follow endoscopically all of your cases after MGB. Same you also follow, because sometimes we eradicate H. pylori, but again maybe reinfection, or you also follow? And have you faced such a situation?
As I told you before, after the surgery, we have a surveillance for 3, 6, and 12 months after the surgery, any surgery, including obviously MGB or OAGP, sorry. And every time we took a biopsy and and it's real that you said, many times we see that these patients reinfect again with the surgery, and they show still Helicobacter pylori.
Sir, what is your finding, this endoscopic finding in MGB? Have you find any silent marginal ulcer after 1 year, after 6 months? So patient has no complaint, everything is fine, everything is okay. But when you did this endoscopy, oh, there is some marginal ulcers. Have you find such a situation?
Yes. It's very curious, because I think that every patient is very different. Sometimes the patient comes to revision, normal revision, and we find silent ulcers that doesn't give any symptoms. And we give treatment, obviously, but small ulcers. And sometimes we can suspect it because in the hematic biometry, we find anemia.
Yeah. Sir, because why I am asking, because now this surveillance endoscopy or follow-up endoscopy, especially after sleeve gastrectomy and MGB, is a hot topic in the world. So now they are discussing about this. What must be it is compulsory or not? So how? Because this is very important. And now in your institution, you are following, and hopefully in future we will have a good data from your side for all over the world and for globe. Yes, we have a center here. We follow routinely these bariatric surgeries, 3 months, 6 months, and after 1 year, and follow up. And this is the data, and hopefully it will be very helpful in future. Sir, question. So question is this regarding hiatal hernia. If you diagnose hiatal hernia before surgery, okay, with endoscopy, or during surgery, because routinely we take consent from our patients. Yes, it may be so it definitely you also take consent. So maybe we are going for MGB. Many times myself also I see this situation, and so at that time MGB was not possible. Sometimes we face, so there is cirrhosis or some in liver issues, and we changed it to sleeve gastrectomy. Due to this, always we take consent from our patients. So what is my question regarding hiatal hernia? In during surgery or before surgery, if you face so large hiatal hernia, or you go for MGB? There is no reflux. There is no reflux.
There is no reflux. Yes, yeah. Yes. We just close the crura, and I think that we don't have problems with this.
There was no issue. Just after cruroplasty, and then
yes, a cruroplasty, and that's all. And after the cruroplasty, we can do the OGB. I think that without any problem.
There was no issue. Excellent, sir. Sir, another question regarding tailored BP limb. Yes, you have mentioned. So in primary surgery, you will never go ahead 200 centimeter. My question regarding redo surgery, a patient with weight regain after a sleeve gastrectomy, there is no GERD, no issue, no reflux, just weight regain. So in such a patient, so patient is more than 50, BMI is more than 50. So he did surgery before 3 years. He touched about 30, 33 BMI, and again weight regain, now reached 50. So in such a situation, what will be BP limb? Are you measure all the length? Have you any criteria in such a condition?
Well, I never saw this condition, but the question is very interesting. We do just 2 meters because in our population, we have a paradox, like maybe in Asia too. We have obesity with malnutrition. And you know, the more longer the BP is, more frequent the malnutrition in these patients. But in the case that you mentioned, in case of this, I think that I will convert this to bypass with a long alimentary limb, maybe 1 meter and 50, and expect that this revert.
Yeah, I understand, sir. Sir, so regarding this, yes, because one of the issue is, unfortunately, in redo surgery, we cannot achieve that target like primary surgery. And so again, weight loss or that excess weight loss is very difficult in such a situation. Due to this was my question. But overall, so you never pass this 200. What is now my question? Have you faced any malnutrition or severe weight loss due to length of BP, and you so changed or so reverse your surgery? Have you faced such a situation?
In these areas that I told you that I present in Egypt, we have two cases of malnutrition. One case, we made a shortening of the limb. In the other case, we reversed to normal anatomy. That I think that now is the maybe many people is doing this because many patients that have malnutrition, they don't want to know nothing about surgery, more surgery, and many of these patients want to return to a normal life. And right now, many patients are asking to return to a normal anatomy after these problems of malnutrition.
Yeah, sir. So what is the main issue? So if we see especially in malnutrition, sometimes because some of our patients, they don't follow properly, and maybe patient face more malnutrition, and also we resuscitate the patient. We can put a gastric tube for feeding, and patient then when recover completely, so then we can go ahead and we can decide which type of surgery is better for our patient. Sir, another question, regarding this, sometime maybe you have faced, personally I have faced, so we do that standard MGB, but unfortunately patient stopped to weight loss. So till 6 months, okay, patient lost 50%, 60%, and then stopped to lose weight. There was standard MGB, BP link, everything was standard as you are doing routinely. Now patient is unhappy, so always, so they have complained, still I want to lose weight. So are you recommend any medication in such a situation, or what is your protocol?
Oh, this is very difficult to manage because the patients are very different, and it's impossible to manage the patients, all the patients the same. And I think that the patient doesn't want more. I think that it's not easy to convince the patient to do different things.
Yeah.
What is specific is your question about the protocol?
So routinely, sir, we use like Saxenda, Trulicity, these GLP-1 derivatives. I don't know. It was my question. So sometimes patients stop to lose weight. Everything is your standard. That BP limb, everything is standard. But so sometimes the patient still want to lose weight. And yes, you also see. So this was my question.
Yes. Sorry, I did not understand the question. Yes, in this case, we use Saxenda because we think, and sometimes we can use another drug, but by the prime line, we use Saxenda with these patients with no very good results. Very good results first 1, 2, or 3 months. After 3 months, we start to increase the doses of Saxenda and then stop again. So I think that it's not easy to manage these patients anyway.
Yeah, I take your point, sir. Sir, one of the most common complication at early stages after MGB is bleeding. Have you faced any time?
Yes, but I think that the bleeding can prevent with a good selection of patients and an accuracy technique. This is very important. We just have to remember that we have institutions, public institutions, that we have programs for training for fellows or residents, and we have to stay every time, every step in the surgery with them, because sometimes small details can produce big problems. In this case, we have a couple of cases of bleeding that resolved by surgery. One of them was a small vessel, that we use, give a stitch and resolve, but we have to reoperate the patient, and this is not the ideal in any surgery. But I think that we have an accurate surgery easily, and we attend every one of the steps of the surgery. We can avoid this early complication.
Yeah, definite. As you have mentioned, sir, so this MDT or multidisciplinary team role is very important. And this is the great point, especially for our youngsters, because you must prepare the patient. Just imagine you are planning or you have scheduled a patient, that is a male patient, central obese, hypertensive. Don't rush for surgery. Just prepare the patient, control this blood pressure, and then go ahead for surgery. Sir, my question, so in such a case, if we are, yes, we prepare the patient, everything is fine, again, are you prefer to reinforce this stapler line, or no, just you go ahead same like this? And regarding the drain in such a cases, is this is your routine practice, put a drain in such a cases, or no, you put drain for all cases?
No, it's not our routine. We always reinforce the pouch, the line of the pouch, because many of the bleedings is localized there. But I never reinforce the anastomosis. But by routine, we always reinforce only the pouch with suture. But that's all we do, because I think that is in our series is not frequent, the bleeding like an early complication.
Yeah, agree, sir, agree. And so sometimes, yes, we face sometimes this gastrojejunostomy, but at the same time, when we staple that area, we can see inside, we can clear that side. And also, because we could not watch your video, also when we do this, close the defect of this gastrojejunostomy, we must take full of this stomach side, because there is the more chance of bleeding. So maybe if there is a chance, we can properly stitch, then there will be less chance. Sir, you can try, maybe you can share your video. Just you can see, share a screen. When you will work with your mouse at your screen, you will see downside. So there will be share a screen. When you click
Yes.
share a screen, you will be just, you can so work with your mouse at your screen, and you will see there is a share a screen button, green color. You will click that, then you will go to your, is it possible?
No, it's a open preference of system. I don't know what is this.
No, there is the laptop. If in laptop, so just you, when you play with your mouse at your screen, you can see share a screen. When you will click share a screen, so then you will go to desktop, and it will be possible for you to share your video.
Oh my God!
No issue, no problem.
What a shame, but I couldn't do it. I'm trying.
Because at the bottom of your screen, so it will come up. When you play with your mouse at your screen, so some icons will come up. So one of them is share screen.
Yes, I have it, but it's impossible to share the desktop. I don't know why, really. I'm so sorry for this. I'm so sorry, I can't. I'm trying to.
Okay, sir. So just I have regarding this, I have because so people want to know your technique. So you can explain. So your position is a French position. You stand between like.
I use French. Okay, I'm going to try to make a resume of the technique. We use French positions. We use 6 strokers to do the technique. We start dissecting the row, the Robin row, and open the window. After this, we shoot our first a cartridge, usually blue. Posterior of this, we put the orogastric tube, caliber 22, and start shooting all vertical to create the pouch with 4 shoots of blue. sometimes the last shot could be wide. We don't have any problem with this. Posterior for this, we count it. We do not count all the intestine from 3 years ago. We count the gut from 2 meters, and then we go up with the gut, and we make the anastomosis, posterior the anastomosis, and we use a stapler with cartridge white, and then we pass the tube through the pouch and the intestine for calibrate approximately 2 and 5 centimeters. Before this, we close, yes, and then we reinforce all the pouch with suture Stratafix, usually the 2.0. That's all we do. After this, we made a hydropneumatic proof with water, just water, no use colorants or anything, and that's all that we do. The patients go home next day, usually with a liquid diet for 1 week, and then for the next 2 weeks with a MASH diet, and posterior normal diet, but no more than 1,200 calories. This is the in resume.
Excellent, excellent, sir. So as you have mentioned, so your pouch length is lengthy till you can. So it is from below calf foot. So your first stapler is below calf foot, and also your pouch is little tight. So just you tight with just like a sleeve gastrectomy, a
Yes.
tight pouch, and your length, this BP limb is average 200. So in a case with the BMI 35 and BMI 60, any difference for BP limb?
No, well, usually we don't make surgery in patients with 35, but in this case, we have surgery is not always the same. As you asked in one of your questions, I am a founder of the tailored surgery. We use the 2 meters because we know that more than 2 meters is very dangerous to provoke malnutrition. But in patients with BMI 35, 35, 36, 38, I will use a biliopancreatic limb, maybe 150, 160, but with BMI 60, I will not use more than 2 meters. I have a panic with this because I saw these patients with malnutrition, and it's very difficult to manage them. Not for the difficulty of the surgical technique, because when the patient comes again with you, especially in a public hospital, they have a very advanced grade of malnutrition, and you have to recover maybe 2 or 3 months before you're planning a new surgery for these patients. This is the principal reason.
I agree, sir. So now because we are also live on Facebook group Global Laparoscopy, and Professor Raul Chapa, he's also watching us, and he is wishes and congrats you by your name. So, sir, yeah. So, sir, we can go ahead. So, regarding this, because in Dubai, so we have guidelines. So we can do bariatric surgery or metabolic surgery for patients with BMI 30 plus 2 comorbidity, BMI 35 plus 1 comorbidity, BMI 40 plus without any comorbidity. This is the guidelines, and we always follow in Dubai. So due to this, I have asked this question because when we face a patient with BMI 40, a patient with BMI 60, so definitely the length of this small bowel will be different. And also nowadays, so they are concluded this, the height of patient is very important. In a patient with more height, there is more chance of lengthy bowel. So due to this, I have asked question, but because you have a good experience and I agree with your experience, so this BP limb more than 200 centimeter, there is more chance of malnutrition, and malnutrition is very dangerous. Then your patient will lose less weight, no issue. If patient will not achieve the target, no issue. But if patient suffering with malnutrition, definitely that is more dangerous. Sir, my question regarding PPI. So how long time you prefer to use your patient PPI after surgery, and which dose you prefer?
We use it post-operative, 6 to 8 weeks posterior for the surgery, and the doses is 20 milligrams at night and 20 milligrams in the morning. That's all we do with the PPI. Okay. And we use just omeprazole. That is the most common PPI that we use.
That is sufficient. So regarding, sir, supplements, how long time you prefer or you suggest your patient to use supplements?
There is a very interesting point, because I have to divide the patients in two categories. Patients from public hospital have a lot of problems to get supplementation, because supplementation, as you know, is very expensive. And the program just covered for 2 years, and not exactly the best supplementation for these patients. And the private patients is very different, because the social economic level of these patients, it's very different. As I told you before, in the public hospital, we have obesity with malnutrition. And the private patient, the patient who have money, don't have this problem and don't have problem to get this supplementation. But usually, I think that we have to use supplementation in these patients forever, because this is the big problem with the money with the patients. I think that you have to supplement, to use the supplementary diet all their life.
Yeah, I agree. So because overall, sir, we also need supplements. If we see our life, so routinely if we check, so there is some vitamin D deficiency, some other deficiencies. So general population also sometimes needs such a supplements. So definite after very, sir, my question, so because your follow-up is excellent and you follow your patients, so after MGB, so which micronutrient deficiency was more prominent in your cases? Just for example, albumin, ferritin, folate, which vitamin was more dominant? So you are using supplement, everything was standard. So can you mention now, so this was, yes, this was more dominant.
Yes, vitamin D and iron deficiency, especially in long limbs. But I think that this is the deficiency that we see with more frequently. Vitamin D, and iron deficiency, ferritin.
This was more dominant in your cases. That is yes. Also common, yeah, common, and we can see. And sir, one of the protocols, so we routinely check PTH after 1 year, because sometime due to hypocalcemia, so this rise of parathormone and also some pathological fracture has been reported. So are you follow this protocol and routinely you check PTH, or no need to check PTH?
No, sir, no, we don't do that, sorry.
Yeah, and also you never face, because your follow-up is excellent and also your patient properly follow. Due to this, maybe there is less chance of hypocalcemia. Sir, another question regarding nizidoblastosis. So sometime in malabsorptive or hypoabsorptive surgeries like duodenal switch, BPD, So we face nisidoblastosis. Have you faced in your experience severe hypoglycemia?
No, no at this time. And the problem with these protocols it's not that we don't want to have these protocols, but we don't have budget because this is a public hospital, and we have many problems to get studies, extra studies for these patients.
Sir, my question. So now, so this is your experience, yes. So are you remember any case, any typical complication after MGB that always irritates you? Oh, okay, this was so very bad, and so what happened to my patient? So because one thing that always I ask, so if you will ask from any surgeon, so have you any complication? If he asks no, then there is two chances. One, he is not doing surgery. Another, unfortunately, he's not like to ask so report. So, sir, regarding this, have you any experience? So that always little so irritate you. Yes, this was.
I think that the worst experience is a bitter experience was when I saw but the first time a patient, a female of 23 years old with a malnutrition. It was incredible because I didn't recognize her. Who's this woman with many problems by carency of vitamins, protein, and this patient was with us more than 3 months preparing her surgery with parenteral nutrition, oral gastro-oral nutrition. And this always put me in alarm with the lung of the limbs. And in these patients, we just, I remember that we use a 2-meter BPLM. But it was incredible how she, when I saw her, they said, oh my God, what is this? No, many times I have it in my mind.
Sir, in my opinion, this is great message really for our youngsters, especially because unfortunately nowadays, so they have access to videos, they have access to YouTube. Just unfortunately in some third world, especially I can mention, there is no standard, no protocol, just a general surgeon. Now in Dubai, general surgeon cannot do bariatric surgery. You must be fellow or must be consultant, then you can do for bariatric surgery. But unfortunately, many of countries, so I don't like to recommend this. So, but they just a general surgeon, laparoscopic surgeon, a video, okay, this is a good surgery, and mini, when they hear, okay, mini is small. No, mini is not small surgery.
No, it's not.
Mini is strong malabsorptive surgery. Mini is very strong than Roux-en-Y gastric bypass. So just imagine, so this malnutrition, so this caused death, liver failure. And I also faced, sir, I faced such a situation. And as you have mentioned, really always it irritates me. So this is a very, so due to this now, I am not aggressive now. Just like you always, okay, no issue. If patient will not lose more weight, no problem. But that malabsorptive, that is very dangerous. Absolutely agree, sir, with you. Sir, my question regarding dumping. So have you faced this phenomena in your patients?
No, no dumping and no chronic abdominal pain, as you asked me no, because I don't remember any case of dumping, and then I can help you with this because I don't have anyone.
Sir, it was very interesting. So same, because these are repeated questions, and it was also for me because mostly one of the I think learner is myself, and I learned a lot from these interviews, and because it was so great opportunity for me. So I also same question asked from Professor Weiner. So regarding this chronic pain, and it was really first time I hear about this. So what was his response to this and answer? So now I also, because you also routinely do this Roux-en-Y gastric bypass, and in Roux-en-Y gastric bypass, routinely this chronic pain is more than mini gastric bypass. So what was my question? Same from Professor Weiner, and his answer was, it was amazing, because he asked, when we make a small pouch of Roux-en-Y gastric bypass, this pylorus is open and always bile is inside remnant, more bile, and we see this bile gastritis and especially H. pylori. So due to this post-op, we must also check H. pylori. There is more chance of reinfection and we must eradicate. So the main cause, and also he showed me some videos that he removed and also that remnant pouch in Roux-en-Y gastric bypass. But when we do this mini gastric bypass, because our first stapler is in antrum and there is a small, so just I can ask, so this is not like completely antrum, and so due to this, what was his hypothesis? So there is less amount of bile inside remnant pouch after mini gastric bypass. So maybe we will not face this chronic pain in patients after MGB. So this was from Professor Weiner. So we respect all of them. Sir, regarding this dietary protocol, so have you you already have mentioned, yes, 1 week liquid, and also then you will start. Have you special protocol for your patients after MGB?
No, no special protocol for them. It's almost the same that for a bypass gastric. It's the same, but not in a special protocol. The only thing is that we privilege the intake of protein because these patients need much more proteins than, for example, and sleep. But no, it's not in a special protocol.
Sir, regarding this, because routinely in high BMI or super or morbid obese, super morbid obese cases, so there is this size of liver is so large size of liver. Are you use high protein diet before surgery?
Yes, sir. Yes, sir. Usually, at least for 6 to 8 weeks, we have this kind of diet before the surgery, because the liver tends to be very big, like a big hamburger, and sometimes it's very heavy. In many of these patients can have important changes in the liver. So it's preferable to give a diet before the surgery.
Sir, because as you mentioned, so you were also in Egypt. I think you were practicing there in Egypt.
So why?
So have you experienced, because you're practicing Egypt?
No. I assist for a congress. I was invited, but
only for a congress. Because what was my question regarding fasting? Because in Muslims, so this Ramadan and also this fasting month, because you know about this. So what was my question regarding this? So if you faced such a situation, when you offer this fasting after surgery, so patient can fast after surgery. Have you faced such a cases or no in your practice?
No, because I used to do surgery, and all my team, my nutrologists, and they take care of the patients. Fasting to me is not recommendable for the Mexican population for the type of diet that we have. And sorry.
Yeah, I understand. Okay, sir. Sir, regarding metabolic surgery, so diabetic surgery nowadays, so this is the hot topic, and one of the treatment of metabolic syndrome, especially diabetes, is surgery. So are you recommend in low BMI cases?
Sorry, I can't see you. I don't know what happened.
Sir, can you hear me?
Yes, I can hear you.
So I can see you. So just, I don't know, but I can see you. Sir, what is my question regarding metabolic syndrome, diabetes? So in a patient with BMI 35 with diabetes, so are you recommend the mini gastric bypass with a short BP limb?
Yes, I recommend it. With BMI 35, yes, I recommend it.
BMI 35 plus, you recommend, so this mini gastric bypass, but with short limb.
With a short limb, of course.
Of course, it will be better results. And So, sir, so because now we also have so viewers and also youngsters. So some of them they will go. They have just now started MGB, or in future they want to start MGB. Any message, sir, for these youngsters?
Yes. First of all, I think that the young surgeons have to know that the bariatric surgery is just a limb of the general surgery. That if you choose to do a bariatric surgery is because you are passionate for this surgery. It's very important that, to know, to learn, and to practice all the techniques. And I think that nobody can be a defender or a preacher of one technique, because every technique have different results and have different indications. We have now one problem in Mexico, that we are seeing the many surgeons just perform one technique. And this is very bad, because what happens if you have to change your mind, or you have a complication during in the operating room. And we have, like leaders, like you, like and others, like many other leaders, their obligations, the conscience to do the things very, very, to be very honest. What are we doing? What we write? What we propose? Because many techniques now are many techniques every day, variants of the same technique, and this confused to the young surgeons. I think that young surgeons must to have eyes and mind always open, because any technique is perfect. Doesn't exist the gold standard in any technique, because time has shown that this is not real. This is my message. Thank you.
Sir, excellent, sir. So really, it was a great honor, and also I have learned a lot because you have shared your experience, and it was great honor for me. Sir, we will also continue our series, because this series we will continue this MGB OGB till June, and then we will start series of sleeve gastrectomy for 6 months. Then we will go ahead with Roux-en-Y gastric bypass, and also this for low BMI, so metabolic surgeries, and then redo. So definite, we need your support after another series, and also so we will like to hear more about your other experiences, as well as in sleeve gastrectomy or Roux-en-Y in future. So it was great experience, sir. It was great honor for me, and really so much thanks for your time. I know you are so much busy, but stay blessed, sir. So really thanks, sir.
Thank you very much. It has been an honor to be with you and with all the audience. I'm so sorry for the video. I'm going to send it immediately to you to see it. If you want to see it, it's a long 4 minutes more or less, but I send you by WhatsApp. I'm so sorry with all of them. Sometimes the technology is not with me, with my residents are not near to me, but I promise next time everything will be perfect. Thank you.
No, it was also excellent, sir. Just you can share your video. So when I will, I can edit this video in your this lecture, and also when I will share on YouTube, and also I will back to you. Please share your video. And no issue, no problem, sir. And overall, you have explained your technique. That was amazing. So much thanks, sir. So this series, we will continue this series. Also next week, we will be with Professor Jamu from India. He is also one of the pioneer of this technique in India, and with a lot of experience. Especially, he has also shared a lot of data all over the world, and his experience, his follow-up, and hope next interview will be also very interesting. And also thanks our viewers that you follow routinely. And my request, you can ask any question by comment, and also during live stream, I will try my best to answer. So from our guest, and also from our these legendary surgeons. Sir, so much thanks, sir. Have a nice time, sir.
Have a nice day. Thank you very much, and I'll send you the video. Thank
you
you very
Thank-
much.
Thank you.
Bye-bye.
Bye.
Ciao.
Thank you.